hypoallergenic dogs. They're so cute. I'm totally biased, but I don't care. They're adorable. But they're hypoallergenic.
Gotcha.
Yeah, they're miniature poodles, but they're not poodle-like. They're very scrappy.
My
I would
grandpup is a miniature poodle.
Oh, nice.
Cute little thing. He's like 12 pounds.
Yeah, well, Rosie is 21 pounds. She's a little bit what we call Zofkic.
Yeah.
And then Axel's a skinny mini. He's 16 pounds. I wish he was more like 17 or 18 pounds. He's very skinny. And even if you give him like steak, he'd be like, well, maybe.
They're picky, aren't they? They know what they
Oh,
want.
right. I'm like, really, Axel? You can't eat steak because it's what? Not good enough? What?
What's that beef, the Wagyu or something like that? Yeah, you gotta,
Yeah,
you gotta.
right.
So your dog is 18 pounds. My cat is 12 pounds. Yeah, yeah. Hey, could I ask when we do this, who usually advances the slides?
Oh, well, I have a copy of them, so I can do that.
Okay.
Yeah.
All right. So if I just say next slide and try not to bark at you, you'll do that for me?
Try to
Okay.
pay attention.
Okay. All right. Perfect. Thank you.
No, thank you. Put our agenda up so as people are logging on, they can see kind of how we're starting off today. Welcome to everyone. So glad you're logging on. And who hit record? Was that you, Ian or
I'm
Chris?
sorry.
I did not.
Oh, I was wondering who remembered to hit record for this meeting.
Yeah, no,
I think,
I start the recording.
yeah, thank you. Appreciate it. I always
Yeah.
until like 15 minutes into it. So welcome, welcome. Thank you for jumping on to our PALTmed Colorado community meeting.
Howdy.
We'll get started in probably about the minutes. Hi. Thank you to Chris and Ian for helping to admit people. I see people still trickling in, so that is great. We want to have a good audience for today. So welcome to our PALTmed Colorado community meeting for March 3rd. I'm Sing Pallet, the president, and we're so glad to have you here for this special meeting. Today, we have several people who have committed to present, so we're going to go pretty quickly. And I'll probably just ask that if you have a quick question, go ahead and ask it. Otherwise, we'll probably like to take our questions in the chat box and offline. But thank you so much to everyone who's jumping on to our community meeting. And today, as usual, we are so thankful for our community partners. We have updates planned from CHCA and the CDPHE, and we haven't heard from them from a while, but Telegen with the Midwest QIN/QIO is here too with some great updates. Right now, it is conference season, so we are in the middle of promoting the upcoming conferences. At the end of March is the National PALTmed Conference in Anaheim, California. I encourage you to attend. It's going to be wonderful CME, amazing experts giving all sorts of presentations, a lot of great networking. And if for some reason you can't bring yourself all the way to California and go to Disneyland with us, you can participate virtually too. And we'll get that link in the chat box. Hopefully during today's meeting, you can just get yourself registered. The other conference that we're promoting is our own conference here in Colorado at the end of April, which is April 24th. And again, we want you all come to the PPA Event Center here in Denver for this one-day conference and earn your CME, learn from our local experts, meet each other. And if you can't make it for some reason, then join us online. So we will get those links in the chat box, and I'd encourage you to spend whatever time you're sitting down today during this meeting, getting yourself registered so that you are ready to go. So you can see today's agenda on the screen here. We have invited the people from Colorado who are presenting at the national conference in California to give us brief overviews and teach us something from their upcoming presentations. So I'm just going to go down this list and we'll do some previews from the first few speakers. We'll hear our announcements from the community partners, and then we'll finish out with more previews of upcoming talks. Okay. I think I see people jumping on, all the right people, and we're so thankful for all of you who have jumped on, as well as those of you who are ready to teach us something about your upcoming presentations. So let us start with the first presenters. Dr. Lauren Hinrichs-Kinney and Dr. Jennifer Stevens-Lapsley. Are you ready?
We are, yes. And it's just Lauren for today. Jen has another call during this time. So,
Okay.
and I'm sorry, I'm just regaining my voice. So if it cracks during this, I apologize. Yeah. But can I go ahead and share my screen and then
That would be great.
Great. Awesome. Thank you. Well, as I'm shifting here, I just wanted to thank everybody, and let's see if I can get this in presenter mode. Great. Does that look okay? Wonderful.
Good.
And I'm going to scoot that over. Okay. So my name is Lauren Hinrichs-Kinney, and I'm excited to give you all a glimpse into what I and my co-presenter, Dr. Stevens-Lapsley, we will be discussing at actually both of these upcoming conferences. So the one at the end of March and then the one in April as well. So briefly, I'm a physical therapist and an assistant professor at the University of Colorado, and also have a research appointment at the VA. And Jen is a professor also in the PT department at University of Colorado and is the director of research in the GREC at the VA. So just a little bit about us. But jumping into a little bit of a teaser. So if you have experience or you've walked through a gym in a facility, you may see individuals working at various intensities. Across my and Jen's experience, we've observed rehabilitation generally performed at what we would call a lower intensity. And so this video you see here is a patient that is seemingly engaging in restorative rehabilitation. Unfortunately, when you take a closer look at the monitor, you see that there's really little to no work being done at this point for about 13 minutes, and that the patient is nearly falling asleep. So it's our mission to really influence practice, promote higher intensity rehabilitation, and optimize functional outcomes for our individuals receiving care in these facilities. So older adults receiving care at a hospital experience rapid strength and mobility loss, which is known as hospital-associated deconditioning, which is strongly influenced by bed rest, immobility, and other physiologic mechanisms related to their pathology or comorbid conditions. As a result of that, we see nearly 1.35 million patients annually receiving rehabilitation at a skilled nursing facility to really address these hospital-associated functional deficits. Unfortunately, we see that 64% of those patients discharging from skilled nursing facilities do so at a functional level that puts them at risk for adverse events. One of those events being rehospitalization at a rate of about 29%. And we believe that physical function is a modifiable factor, which can be influenced by the rehabilitation care delivered. And so for this reason, we developed a progressive rehabilitation program called iStronger that really aims to promote just a culture shift in rehab. So instead of having a majority of time spent on general conditioning activities, we're actually spending a majority of time on more high physiologic intensity activities, including resistance training. And so with this program, we leverage muscle strength and hypertrophy principles that then translate into functional gains. So specifically, patients are dosed at an intensity where lower reps and high intensity are encouraged. And so specifically, we're going to ask a patient to do an intervention or an exercise for around, or at an intensity rather, that 8 reps is challenging. And they really can't perform that 9th rep. Instead of doing 20 repetitions, 30 repetitions, we're really taking the volume of repetitions down, but increasing that level of challenge or that level of intensity that they're working at. So we did some pilot work. After that pilot work demonstrated effectiveness of the program, we sought to study the effectiveness and implementation across diverse skilled nursing facilities across the country. So we were very fortunate to partner with Aegis Therapies as leaders in the SNF industry. And their willingness to invest in learning really created the conditions that we needed to implement this at large scales because we ended up enrolling 30 sites. 15 were randomized to deliver care as usual, and then 15 sites were trained in and encouraged to deliver that high intensity program. And that happened across 15 months. So across those 15 months, we trained 140 clinicians, which was amazing, across those 15 sites. And we have outcomes data from over 4,000 patients to analyze, or we have analyzed, to understand program effectiveness. The really great thing, I think, is that we were able to learn from all these amazing people that you just saw go across the screen. And we hosted 170 focus groups and interviews. So the study is not really just trying to understand, does high intensity rehab, does iStronger work or not, but really, how does it work? Why does it work? And what does it take to get it to work in diverse contexts? So more to come. We're going to share those results at these two upcoming presentations. And if you are unable to make those, I put my email here if you're interested in reaching out or learning a little bit more. So I will stop there.
Great. Thank you for investing in our rehab patients
Mm-hmm.
and presenting these to us. Well, let's go to Doctors Allison Lange and Matthew Griffin. Welcome, Allison and Matt. Good to see you guys.
Thanks. Matt, do you want to go first or do you want me to go first?
Why don't you go first?
Okay. I need just a couple of slides, and since there are two of us, I will keep it brief. Can everybody see that?
Yes.
You can see it.
Okay, great. So Matt and I are going to give a talk jointly with Nicole Orr about clinical updates in COPD, sleep medicine, and heart failure on March 26th in Anaheim. And I'm going to talk specifically about COPD. So I am a clinician primarily at the Eastern Colorado VA healthcare system, also doing research. I practice pulmonary critical care and palliative care there, and I have no disclosures. So first, I want to talk about, why does COPD matter in the acute and long-term care population? The first three reasons I came up with when I was thinking about this is primarily related to symptoms. Dyspnea is a pervasive symptom in the post-acute and long-term care population. Different studies will quote 15% to 60% of patients experiencing dyspnea. Chronic cough is also incredibly common, and patients with COPD also suffer from poor quality of life. There's also an association with depression and anxiety. And then lastly, there is an increase, these patients have an increased risk of cognitive dysfunction compared to people without COPD. And they experience frequent hospitalizations and ER visits. And I think the subset of patients in post-acute and long-term care are especially at risk for all of these things. During my talk, I'm going to talk about the diagnostic criteria for COPD. We're going to review them briefly now, and then we're going to go over the GOLD guideline updates in 2026 during our talk. So hallmark symptoms of COPD are cough, shortness of breath, and sputum production. And essentially, you have to have one of the things from each of these buckets. So you have to have some symptoms, you have to have exposures that are consistent with COPD. The most common exposure we think about is tobacco smoke, but really biomass fuel exposure as well, or air pollution. Biomass fuel exposure is when people burn wood, animal waste, crops inside their home, and it's not well ventilated, and that essentially creates air pollution within the home that leads to COPD. Genetic predisposition from primarily alpha-1 antitrypsin deficiency, and then you also have to have fixed airflow obstruction on pulmonary function testing, so a ratio of your FEV1 to FVC of less than 0.7. And then we're going to talk about challenges in COPD care for older adults. I think there are lots of these that we'll dig deeper into in my talk in a few weeks. I think number one is an incorrect diagnosis. So not having one of the things that I mentioned on the prior slide. Incorrect inhaler technique is unfortunately incredibly common. And I think the coordination that it requires to push your inhaler, breathe in, do it all at the same time is very difficult. Polypharmacy, and I think we treating COPD add to this with steroids, azithromycin, roflumilast, unnecessary use of inhaled corticosteroids. Exercise, we just heard from someone who knows how important exercise is, and it's just so hard to implement. And then lastly, I think self-management is really the cornerstone of managing COPD, but it's really hard to do that in certain populations. And this is my email if you have questions. Matt, I'm going to stop sharing so you can talk.
All right, thanks. Like Allison said, we're going to be giving kind of an update talk, less about presenting research like the first one on COPD, CHF, and sleep. I'm a pulmonary critical care and sleep medicine doc at the VA. Primarily, I hold an appointment at University of Colorado. Let me share my screen. I'll be handling the sleep. I will not put it in presenter mode just because I didn't make a separate slide, and if I do so, I'll lose my video of you guys. So I'll be talking about some of the objectives of my talk will be on recognizing common causes of sleep disruption in post-acute long-term care residents, identifying signs and symptoms of obstructive sleep apnea, circadian rhythm disorders, other common sleep conditions, and really talking about how to implement some practical non-pharmacologic strategies to improve sleep, which will also hopefully reduce falls and delirium. And then if we are going to be prescribing, applying safe and evidence-based prescribing practices. So why sleep matters in your settings, it influences rehab participation, as we just talked about. The patient's falling asleep while they're doing their exercise. Maybe they didn't get enough sleep last night or good quality sleep. It affects cognition, delirium, influences mood and behavior, impacts fall risk, impacts cardiovascular health, and affects staff workload. If patients aren't sleeping at night, that staff's not going to be able to get all their work done. Just some common myths about sleep as we get older. There's a common myth that older adults need less sleep, and it's true that when we're children, we need more sleep, but that kind of stabilizes once we hit our teenage years and get into our early 20s. Adults sleep lighter and less efficiently, so they still need about 7 hours a day, but they have decreased deep sleep, which makes them more vulnerable to environmental disruptions, noises, from roommates or med passes or staff walking by the room. They have decreased sleep efficiency. They tend to have advanced circadian rhythms, kind of the early to bed, early to rise. And then as patients, particularly with dementia, they have less stable circadian rhythms. So sometimes their sleep schedules can get off from what we would consider typical calendar or clock schedules. I'm going to skip through some of these slides because I didn't make a special one, but highlighting that home testing or in the field testing for sleep apnea has become much more feasible over the last few years. The CDC estimates that among people over 65, 50% of women and 80% of men have sleep apnea. And so, those numbers are really increasing because of the access to home testing. We used to have to put everybody through a polysomnography, so we only tested people with high pretest probability. Now that we're testing everybody, we're finding sleep apnea a lot more. And some of the modern testing devices, like the sleep image ring you see on that person's thumb, or the WatchPat one, which is entirely disposable, have really expanded access to sleep apnea testing. As I mentioned before, circadian rhythm disruption and dementia. So dementia often leads to what's called sleep-wake rhythm disorder, or irregular sleep-wake rhythm disorder, which has unstable day and night sleep patterns, leads to increased wandering at night and fall risk. And I'm sure all of you guys have seen this. May play a role in sundowning. And there's been a lot of evidence lately on therapy to improve this, which I'll get into in a second along with my updates. So just some common updates. So sorry about the formatting on this. Sleep apnea treatment. There's been a shift more towards auto titration and remote management, less of a need for polysomnography. Almost no need now. Medicare is covering remote telehealth visits for CPAP prescription and adherence confirmations. There's less need to bring your patients to a sleep doctor. And there's ongoing advancements in mask design. And I highlight some of the more modern masks that no longer cover the nose and mouth. And because the patients can't see them, because they're not covering the nose anymore, they're less likely to cause mental health symptoms like PTSD exacerbations and delirium. All right, I know that I'm running out of time here. In terms of meds, I want to highlight a few new medications on the market. The DORA medications, lemborexant, suvorexant, and daridorexant. Those may be less likely to cause some of the falls and other sleep behaviors from the classic Z drugs. Also, the American Geriatric Society has recommended doxepin for first-line use and their update to the Beers list medications. Doxepin and trazodone have generally been used often for help with sleep. And low-dose doxepin is preferred over trazodone by AGS because it's more evidence-based, particularly for sleep maintenance, lower risk of orthostasis and falls, fewer anticholinergic effects, less next-day sedation. Melatonin, there have been a couple big reviews of melatonin that have come out in the last few years. And although melatonin is not a hypnotic in adults like it is in children, generally they found that 4 to 5 milligrams of prolonged release melatonin given around 6 p.m. can help kind of lock in that circadian rhythm for your patients that have unstable circadian rhythm, as well as have a modest improvement in sleep onset. And then lastly, but not least, light therapy. So again, there have been multiple meta-analyses published since 2022 among older adults, specifically those with AD and ADRD, Alzheimer's dementia. They recommend to help kind of stabilize sleep patterns, an ideal exposure of 6 to 10,000 lux at eye level, about 90 minutes between 7 and 10 a.m. And it's shown improvements in subjective sleep quality, circadian rhythm stability, sleep latency, and sleep efficiency. So these are some of the topics that we're going to be getting into, as well as some to-dos for you to take away with you, and some take-home messages, which is that sleep is restorative for people of all ages, happens when we allow it, remains important throughout our lives. Improving sleep in post-acute long-term care is not necessarily about prescribing the right medication. It's about supporting deprescribing, circadian alignment, and identifying and treating the right patients. So please come to the talk for more information. Thanks.
Thank you. Wonderful having two pulmonologists right here with us. Chaplain Donovan, thank you for joining us. I think you're presenting twice at this upcoming national conference.
I am. Thanks, Zing. Thanks, everyone. Well, some of my group members actually had some unexpected travel, so we don't have all the slides perfectly and pretty yet, but I'll just give you guys kind of an overview of both talks and would love to see you at either or both. The first one, so I'm working with Sarah McAvoy. She's another chaplain at a continuum of care, as well as Dr. Fatima Nakvi, who's also, she's a physician at a continuum of care and also professor at George Washington. And the first one that we're collaborating on, Sarah has actually received some funding from the Chaplaincy Innovation Lab to develop some training that we're hoping to incorporate into the medical director certification core curriculum. And so we're going to hopefully beta test a little bit. This is the 3.5-hour workshop format, training on spirituality and medical education and practice. So I'm excited about that. Sarah actually sent a survey out that you may have seen come across your desk where people gave us some really honest and valuable feedback about barriers to providing spiritual care, like generalist care, essentially, and what concerns are, what hangups are, why it may or not feel prioritized, what barriers might be to providing care, and to just diving into the content. So we're really excited to provide some of that training, consider what it could look like to develop some modules for the core curriculum. Diving into things like the biopsychosocial spiritual model, which typically doesn't have, that's a new addition, the spiritual model, the National Consensus Project for Palliative Care, and the kind of a working definition of spiritual care, the generalist specialist model when it comes to spiritual care, which is the way I like to think about it. And I know Sing, you and I've presented on this, what it looks like to empower all of us to be generalists, and then to know what you don't need to worry about, what you can kind of try to tend to ourselves, and then also hopes that a generalist might be available, and then how to find one if it's that's not as easy as it should be. Tools for practicing compassionate presence, and things like if you get asked to pray at the bedside and you like when that's appropriate and when that's really not. What if you don't feel comfortable? So really empowering our providers to also not feel like they have to step into something that feels uncomfortable to themselves, but also empowering them to know that all the research indicates patients actually really want their providers to ask them about that part of their lives. And it doesn't have to be, a lot of what we'll do is differentiate between religious care and spiritual care. Some overlap, but huge distinctions there. I'll pop in the chat some of the fun research. The third module, the third part of what we'll talk about is our own spiritual well-being and how that connects to our ability to care well for patients, the possibility of bias and countertransference when we're not practicing that self-awareness. So the magnitude of what it means to have that kind of being tuned in with ourselves. Well, again, whether or not you practice a formal tradition or not, just having those practices of self-awareness and integration of the heaviness of the work as well as the beautiful. And so one of my favorite recent discoveries and articles is the Sacred Moments Initiative. This I'm hoping to do live is give people a chance to reflect on sacred moments in their work. And again, sacred just meaning like powerful, what they call them, another way to describe sacred moments, they use the term sudden intimacies, like a sudden awareness of like how beautiful that these two human beings are sharing this powerful moment in this space. So I'm really excited about that, as you can imagine. So we'll spend a little bit of time on that. Feel free to check out that link in that work as well. So that'll be a big workshop, but again, I'm hoping that it will be really hands-on and helpful. And then also we're going to take our notes from the time and use it to kind of continue developing that training. And then the second talk, this is a 90-minute talk with also with Dr. Fatima Nakvi. So we met at AMDA several years ago, keep running into each other. And then we both ended up in the same program for studying narrative medicine through Columbia University, starting at the same time. So it was really serendipitous. So she and I are also going to present on narrative medicine. She has noticed the impact of doing this coursework for herself on the impact on her as a provider of becoming more empathically connected, more patient, being more of a close listener to her patients in her own setting. I have been doing a lot of work at Optum with using this work to support staff, to support our healthcare workers as well as non-clinical staff. So we're going to be presenting some of the findings of our work in our various settings and using it to really, that'll be a hands-on workshop as well. So the three classic elements of narrative medicine are engaging with literature, art as a way to, it's almost a form of mindfulness, slow our mind, give ourselves a chance to look at a piece of art and use it as a way to reflect on our own inner experience, our clinical experience, things that we maybe haven't had a chance to reflect on or honor, and to do it in a group setting so that you can learn from one another. So the three objectives as defined by Columbia for narrative medicine are attention, like developing our capacity to attend to the other and the self, representation, the ability to give voice to what's going on in here, all the things we carry around, the richness of experience and the heaviness of it that we never pause to really express ever, and affiliation, the chance to hear the experiences of the others in a way that is connection building, especially across different disciplines. So we'll get to do that in real time. If you want an example, there's a really cool magazine called Intima. It's a journal for narrative medicine. And this art that you see, if you scroll down a little bit, is a beautiful painting of a window it looks like a hospital setting with a hospital bed. We'll use that for some creative writing. So just some fun quotes from, we've been doing this for almost a year now within my setting at Optum. But we had several cohorts that we ran last fall. Someone said, this helped me understand that it's normal to need to process after a hard patient experience. Instead of holding everything in, I'm able to get it out or express it. All I have to do is pick up a pen and go. Everyone has stories and they're all important to communicate. So really cool feedback. We've seen reports of improvement on physical and mental well-being, enthusiasm about work, feeling less detached about work, feeling more energized to do your daily work. And then some really cool reports from managers of those who participated as well, increase in productivity, employee engagement, and employee satisfaction. And that seems to match up with some of the research that Columbia and others are doing out in the world on impact of this work on using the humanities in these really small moments. It doesn't have to take a lot of time, but really small moments to let people process what it is they carry every day. So I'm really excited about it. Would love to see you all there, and would love to bring this to this chapter at some point too, if that makes sense at some point. Happy to bring it here. Thank you all.
I appreciate you taking care of our patients and taking care of us.
My job.
Now I'll let Dr. Chris Horton guide us through our announcements from community partners. And on the screen, you can see the other upcoming presentations.
Good afternoon, everyone. We have, I don't know what order we're going to go in. We have Chad here with the CDPHE. Would you like to start us off, Chad?
Sure. All right. I just had a few things that I wanted to share with y'all. And the first was I have an update on immediate jeopardy situations. We've had 17 year to date for the federal fiscal year. So since October 1st, 2025, we've had 17 situations that have constituted immediate jeopardy. And these have included issues such as elopement, water temperatures, resident-to-resident physical and sexual abuse, offering immunizations to prevent the spread of highly infectious diseases, respiratory care, catheter care, significant medication errors, primarily right now involving anticonvulsants, insulin, antivirals, and anticoagulants, advanced directives, choking related to inappropriate food texture, bladder care, and well, I had advanced directives twice, did only once. So that's the list of situations that have risen to that particular level, and I wanted to bring that to your attention because this is something that I think you'll be asked to or have addressed in your quality assurance processes with your involvement with quality assurance. Earlier today, we met with the Nursing Home Roundtable, and we had a conversation about frequently asked questions. And the area that leads to the most questions have been transfer and discharge. And I just wanted to bring to this group that pertinent to the role that many of you have, you may be asked questions during survey about your documentation of specific needs the facility could not meet, facility efforts to meet those needs, and the specific services the receiving facility can provide that the current facility cannot. As the medical director, you may be asked questions about the facility assessment and quality assurance oversight of the facility's policies and practices related to transfer and discharge. That's kind of a summary of an hour-long conversation that we had earlier today. But that's what I have to bring to you. If there are any questions.
There is a question in the chat from Dr. Leslie Eber. Is there a way to get a list of the IJs?
Could you say that again, please?
There's a question in the chat. Is there a way to get a list of all of the IJs?
The 17 IJs that you just listed, could you share them in a list or something?
And I can give you more of the specifics related to the situations. Yes.
Totally appreciate it. Thank you.
Great. Thank you so much for the update, Chad. Let's move on to Jenny Albertson to give us an update from CHCA.
Hi, everybody. I will just do a couple of very brief slides here to get you up to speed. I also have some description of the immediate jeopardies I'll send over to you, Leslie, too, that gone back a little bit. Updates on legislation. We are in the thick of the legislative session. Wanted to let you all know that the injectables legislation that we were all pretty worried about has been backed down. It was a combination of a requirement for people who are advertising memory care to submit particular information to the state via a specific form created by the state and then make that available to consumers. That has been modified to make it less dependent upon CDPHE. We yelled and screamed about how they already had plenty to do. So this is more of a consumer-facing document now and intended to be part of the facility's marketing requirements. And then the bill sponsor looks like they're going to back off completely on the injectable medications that they were pushing for in the assisted living setting. They wanted to go beyond scope of practice and permit CNAs to do insulin administration, which scared the jeebies out of a lot of us, and we testified against it. So she's been very amenable to conversation with us. So that's going to come off the table. You can breathe a sigh of relief. The other bill that I thought was very pertinent to what you all do is the end-of-life care for medical marijuana bill. It is going to allow a health facility under Colorado state law to aid a terminally ill patient in the use of medical marijuana if they are a permitted user. It does not create a requirement. Since most skilled nursing facilities are duly licensed with federal requirements, we will not be able to participate in that. But for those few providers that are private pay only, they will be then permitted to administer medical marijuana for end-of-life care. And a bit of good news, there is an $80 million notice of funding that was sent out by CMS. They are asking for fund administrators at each state level to run a tuition reimbursement incentive program for retention of nurses in skilled nursing facilities and in state survey agencies. And they're also going to be paying stipends. So it's a pretty substantial amount of money available to each nurse. We don't know who's going to win the contracts to administer the the fund, but it looks like hopefully we will be able to take advantage of some CMS dollars for that. So that's exciting. We as an association, we always get this question, are not permitted to apply to be the fund administrator. This is a resource that's available to you all that was put out jointly by CDPHE and another organization that crafted it. It's an e-learning. Apparently the red flag laws that have been spread around the country, we have one in Colorado specific to healthcare providers. If you feel that there is a resident under your care that is at risk due to their possession of a firearm, you can ask for a 14-day up to extension of a year protection order for them to not have access to their firearm as protection to themselves or others. And this is an e-learning explaining to us how that process works. It is something very specific to healthcare providers that they just legislated recently. And our upcoming events in education, best practices in dementia care is the one coming up soonest. And the wound workshop is at the end of March 31st. Thank you so much.
Thanks, Jenny. Any questions? I think we'll move on to Dr. LaRocca and Courtney Ryan for an update from Telegen, or
Thank you so
new organization.
Thank you so much, Chris. Thank you, Singh, everybody, for this opportunity to speak to you today. I'm Christine LaRocca. I'm a fellowship-trained, board-certified geriatric medicine physician. I'm a certified professional in healthcare quality, or CPHQ, and I serve as clinical lead at Telegen. I provide clinical oversight and subject matter expertise for the 14 states that are in the CMS Midwest Quality Innovation Network Quality Improvement Organization, as well as serving as a clinical lead for 2 national federal bundle payment models. I live here in Denver with my husband and my geriatric cat, and I have 2 grown sons. So this slide deck has a lot more info than we have allotted time for today, but it's going to be shared with you as a resource. We jumped at the chance to have 10 minutes on the agenda since our enrollment period ends in less than 3 months, or at the end of May of 2026. So if we could go to the next slide, please. Here's our agenda. We're going to emphasize early and often that all of our quality improvement support and services are at no cost. Well, why is that? Because we're funded through the Medicare trust funds. So as I like to say, you paid for us already, so why not benefit and see what we have to offer? So next slide, please. And we can click through this one and the next one and go to slide 5. Thank you. The QIO program is actually required in the Social Security Act. Sometimes I'm sad that it's still a sleeper program because I have spent 25 years of my career with the Quality Improvement Organization program. The primary purpose of the program is to improve healthcare quality by partnering with and providing expert technical quality improvement assistance to support providers. We have a spirit of service when we work with providers. We know you all are experts and the answers are in the room, and we meet you where you are. We do not serve a regulatory role, which is what many people think of when they see CMS. For this most recent scope of work, Telegen and another very long-standing quality improvement organization called Mountain Pacific have partnered together, and we won this award by CMS. It was very competitive. I'm coloring my hair more often now. For this 5-year contract. A huge thank you to all of the people in attendance, too many to name, who provided us with really heartwarming letters of support, and I truly believe they were instrumental in this win. So if we go to the next slide, please. So what is different this scope of work is that CMS actually regionalized the contracts. It used to be you could pick and choose which states you thought you were a good fit for and bid on those states, and if you won them, they were yours. But the country was divided into 7 regions. Last May, our team was awarded the 14 states shown here, kind of called the Midwest region, which is a very expanded definition of the word Midwest. Try telling that to Oregon or Alaska. It's very exciting. We now support 28% of the states in the US and the largest region. Next slide, please. Another difference for the current work is that while we offer services to all providers, and we're focusing on 3 settings, nursing homes, hospitals, and outpatient providers, we are asked to provide more intensive, customized support for an eligible subset of providers. And Courtney will speak more on that. A huge thank you to all of you who have already enrolled with us. We want to get to 100% though. We're an A+ kind of driven organization, and we hope the remaining eligible homes will sign up. If you reach out to Courtney, she can tell you if your home is eligible for this more intensive assistance. This slide shows a letter we received from CMS to share with providers describing the benefits of partnering with us. I want to emphasize that participation with us is voluntary, which is why we need a signed agreement indicating willingness to participate from eligible providers. So if we can go to the next slide, please. So here are the priority areas for this 5-year contract, both foundational and clinical. It is important and exciting to see these foundational priorities to include cybersecurity assessments. A ransomware attack can be absolutely devastating, workforce planning and retention, and supporting the use of up-to-date ONC certified health IT that meet requirements, those standards to support interoperability. Let's go to the next slide, please. Here is more detail on the nursing home specific quality improvement focus areas. Once you receive the slides, you'll see that there is wonderful alignment, great alignment with the data you're already collecting and reporting, because we're committed to decreasing data reporting burden. Next slide, please. So this slide and the next provide more detail on the innovative offerings our subject matter expert, Meredith Koob, has developed as part of our workforce support. If we can go to the next slide, please. One example, I mean, I'm hearing about nursing homes around the country that have successfully implemented on-site childcare. I'd be very interested to know if any Colorado homes have done that. So it's childcare for their nursing home staff to decrease absenteeism. I'm hearing that there are some pros and cons with that. I know my own children, when they were young, could be very distracting. But it is a really clever idea, and we can help connect interested homes with those that have done this successfully for lessons learned. We can also provide data analytics support to help you trend your turnover and absenteeism, identify scheduling gaps and early warning indicators to review with your leadership team. Next slide, please. This slide provides details about our support for antipsychotic medication management, emergency department use and readmission reduction, and emergency preparedness. And I hope the predictions are wrong about the increased risk for wildfires this year, but please know we have an expert, Brian Feist. I dubbed him Mr. Disaster, and he loved it, to help eligible homes with your hazard vulnerability assessments. Next slide, please. And here you see specific examples of how we may help eligible homes to improve cybersecurity and interoperability. So if we go to the next slide, I'll turn it over to my absolutely awesome colleague, Courtney Ryan.
Thanks, Dr. LaRocca. Good afternoon, everyone. So our quality improvement assistance incorporates the short stay and long stay quality measures that your homes are already collecting and reporting. All of the nursing home focus areas that Dr. LaRocca discussed a couple slides ago are tied to the 5-star quality measures. So we will work with you to identify quality improvement opportunities that are aligned with improving star ratings and can provide data trends and benchmarking. Next slide, please. New this scope of work are the focused QIO service or FQS referrals. We received these referrals from CMS to offer just-in-time boots-on-the-ground assistance to meet urgent and emerging needs. It's somewhat similar to our role in the last scope for the pandemic, where CMS instructed QIOs to actively assist with COVID outbreaks in nursing homes. The FQS referrals are voluntary and will be issued in what CMS refers to as sprints, lasting 15 or 30 days, and these can be conducted either on-site or virtually. Next slide, please. So why join us? Next slide, please. Our main objective is to personally connect with every provider. Our approach is collaborative with deep respect for your expertise and your experience. And as Christine mentioned, we lead with a spirit of service to come alongside, meet you where you are and with what you're ready for. Each provider is assigned a quality improvement advisor as their point of contact, but we also embrace a no wrong door approach. Providers can reach out in any way that they're comfortable. We have a general email box that is accessible from our website, on our business cards, and in all of our communication materials. And we are also fully committed to offering timely assistance no matter how a provider asks or gets in touch with us. Next slide, please. For eligible providers invited to participate and enroll in our program, we offer intensive, customized face-to-face support, individualized technical assistance in priority areas, and this assistance will come from your dedicated quality improvement advisor, along with access to our internal subject matter experts. And again, will be a combination of both in-person and virtual support. We will provide ongoing monitoring of progress and assistance with data collection, use, and interpretation, and providers will have access to timely data relevant to their home and compared to regional and national benchmarks. Next slide, please. This slide is important to note. All providers who engage with us, regardless of whether they are enrolled, have access to the services listed here. Our services include tools and resources that relate to quality improvement activities, as well as clinical guidelines and change packages to assist with improvements in specific areas. We intend to offer educational events as well as customized peer learning opportunities across our 14-state network so that providers can learn directly from others who have undergone similar initiatives and overcome common challenges. We will also distribute information related to trends in the healthcare landscape, changes to existing programs, new initiatives, and value-based payment models emerging at the local, state, and federal levels. Next slide, please. The next two slides are specific to Colorado nursing homes as it relates to opportunities to partner. Next slide, thank you. This graph displays aggregated data for the 99 Colorado nursing homes that are invited to participate in the QIO program and what we're seeing as the priority areas for our nursing homes across Colorado. The measures are shown in rank order from highest to lowest based on the percent of nursing homes that have been identified as having improvement activities in each of these measures. So you can see 81% of the eligible homes have opportunities for improvement related to antipsychotic medication use, followed by 75% with opportunities related to pneumococcal immunizations. Influenza and falls are pretty close in terms of rank, and so on and so forth along the chart here. Next slide, please. All of our focus areas and TA also can be mapped to a business case based on the Colorado Pay for Performance Medicaid program. This table outlines the results for the 2025 performance year, and I just pulled out the top 3 opportunities for Colorado here just to highlight the alignment between the quality measures selected by the P4P program and the focus areas we as the QIO are prepared to help you improve, namely the Director of Nursing and Nursing Home Administrator retention through our new workforce service line, transitions of care, and improving the UTI quality measure. Next slide. And one more, please. And this just goes over that participation agreement that Christine mentioned. I'll just quickly touch on this. It's simply a participation agreement to formally partner with the QIO. The main key takeaway here is that this agreement is not financially or legally binding, and I'm happy to review this in more detail with anyone that is interested. Next slide. I know you mentioned to put questions into the chat, so I'll peek over at that. And if you go to the last slide, that has our contact information. So please feel free to reach out with any questions that you have. And thank you so much for allowing us to share more about our role and the support we offer. We're really excited to serve you as the QIO for Colorado. So thanks for having us.
Thank you very much. Christine, you mentioned intensive assistance program, or what criterion are you looking for? Is that any facility that wants to participate? Or are you looking for specific types of facilities?
You're on mute, Christine.
Sorry, there we go. One of these days. It's a great question. This is the first scope of work where we got an identified list of eligible providers. The criteria around that, to the best of our understanding, while it may be opportunities for performance improvement, it also included homes that maybe are located in areas of high area deprivation index, maybe have a more vulnerable, less resourced population or community. And there's a real commitment from CMS, as we've seen with the Rural Health Transformation Program, on rural health. so for instance, every critical access hospital, nearly every, there's a couple of tribal hospitals in our 14-state region is on this eligible list. That said, if you reach out to us, we find a way to yes, but that in order to be good stewards of taxpayer dollars and be able to come on site for some of this customized support, it is a subset, roughly half of Colorado nursing homes. Is that helpful?
Yes, thank you very much.
And any home could be could potentially get one of those FQS referrals like we saw during COVID.
Perfect. I just want to thank you again, Chad and Jenny and Dr. LaRocca. These are very helpful updates. I'm going to turn it back to Sing.
Sounds good. Yeah, let's continue with our conference presenters. I know we'll probably run out of time. I won't go today, but we do have our journal club on Thursday, and I propose that we continue further updates at that time. But why don't we move on to Doctors Clark and Eber, who will talk about their presentation on gabapentinoid deprescribing.
Thank you so much, Sing. Sophie, are you ready to start?
I sure am. Yes. Can you guys hear me?
Yeah, you're perfect. Just tell me when to change the slide.
All right, perfect. So today we wanted to talk briefly about our deprescribing campaign that took place across a large nursing home chain. And we just wanted to start off by just reminding people about the harms of gabapentin.
Yeah, hold on a second. Oh, do you want to do the trends or do you want to?
Sure, yes. So gabapentin, as you guys are all aware, is prescribed for a number of different indications but it's really only approved, FDA approved for partial seizures and postherpetic neuralgia. However, it's really commonly used off label for neuropathic pain, other pains, depression, behavioral symptoms, you name it. And those other uses are really what's driven its increase, and its gabapentin prescriptions have tripled from 2002 to 2015. So really has skyrocketed in terms of prescription. And then older adults older than 65 are disproportionately affected. And really common side effects of gabapentin, and oftentimes gabapentin is not effective for the reason it's prescribed and has a lot of unintended side effects. So certainly has dose-dependent CNS depressant effects, so dizziness, drowsiness. When you're using it in combination with other medications like opiates and other respiratory depressants, it definitely can cause respiratory depression. It's a big cause of peripheral edema, so something to have on your differential when you see someone with lower extremity swelling, and then other GI side effects, low blood pressure, and then can just trigger delirium. Pregabalin, very closely related to gabapentin, so has a lot of the same side effects as gabapentin, but with the one difference being that peripheral edema is more common than with gabapentin, but shares the same risk of CNS depressions, especially when combined with other opiates and other risky medications, and then can cause hypotension, weight gain, blurred vision, headaches. So certainly a lot of reasons to stop these medications. So I will let Leslie sort of give an overview of how our deprescribing campaign went.
Okay, so we did this intervention, and I kind of we're gonna just wait to share some of our details, of course, in our talk in Anaheim. But what we found is as you see, the blue bars is the immediate effect. The green is 3 months after our intervention, and then the gray is 6 months after our intervention. And what we did is we shared bite-sized learning for all of the nursing homes, and then we had a high-intensity group of 16 nursing homes. We met with them monthly, but it was a short meeting. And what we did is we partnered the clinical pharmacist, the director of nursing, and the administrator, and also the medical director. And we tried to get everybody on the same page to understand why we wanted to promote deprescribing, and specifically deprescribing gabapentin, and to see if we could also have effect of gabapentin plus opiates. And as you see, the immediate effect was pretty large. These are the 16 high intensity nursing homes. But I think the most interesting thing is when we looked at the gray bars, some of the sustainability, and a lot of time these gray bars are actually above what happened at 3 months. So our sustainability for the effects on deprescribing gabapentin, and especially gabapentin plus opiates, were sustainable with this bite-sized learning and incorporating the entire community within this nursing home chain. And so how could you do this at home, at your home? We have a 6-step way you can do gabapentin deprescribing, which we highly recommend, or you could do falls, or you could do antipsychotics, or you could do a safety measure. But what we found worked, and why we thought that we had some sustainability, is recognizing an agreement on the problem, explaining the why does it matter, and getting the buy-in from the leadership and the community, both. Engaging in interprofessional stakeholders, we engaged our clinical pharmacists, nursing, medical directors, and establishing how we're going to do the intervention. So we really had a good plan. We reviewed baseline data, and then we created the campaign and educational materials. And we shared the real-time data during each meeting. So every nursing home in our high intensity saw how they did this month and last month and the month before, and they took that back to their meetings and to their homes. We shared lessons learned with the whole organization. We talked about barriers and successes, and then we really invested in that idea of sustainability. So we hope to see you in Anaheim, and thank you.
Great work.
Learn how to unshare. Hold on. Okay, thanks.
You know, we have 6 minutes left, and we were hoping to hear from Alan, Raj, and Carrie. I'll let you guys kind of decide how you want to divide up the time. And if anyone's available to come back to Journal Club this Thursday, we'd love to hear from you that time too. Alan, would you like to hear?
Alan, you go ahead. I just have a workshop and I can include slides.
I'll be very quick. It doesn't make a difference to me.
You go.
Okay. Yeah, I'm honored to participate in 2 panel discussions, and I will be very brief. The first one is, are you prepared to address ethical dilemmas, introducing the PALTmed Ethics Toolkit? And I was honored to be a member of the PALTmed Ethics Subcommittee, and we spent a considerable amount of time over longer than a year, and hope to have the Ethics Toolkit available. I think it's waiting for final approval at this point. The panel members are Dr. Katja Elbert, Avila Timothy Hollerhan, and Howard Finger. And again, I'm honored to be there. Let me just say one thing, and the reason that I think I was asked to be part of that panel discussion is because, as everybody on the call knows, ethics is a regulatory requirement. CMS requires that every skilled nursing facility that participates in Medicare, which is essentially all SNFs, have a compliance and ethics program. The regulation requiring that is at 42 CFR 483.85. There's a separate regulation at 483.95, which deals with additional requirements. I won't go through them all now, but there are 8 discrete requirements that CMS mandates for every facility. And if there's an operating organization with 5 or more facilities, there are 3 additional requirements, such as annual training, and they must designate a compliance officer and have compliance liaisons at each of the 5 facilities. Let me just say one final word about compliance and ethics, because there seems to be some confusion. There's no CMS requirement for an ethics committee. The requirement in both the Affordable Care Act, which authorized the regulation, and the regulation itself is for an ethics program. So that's largely left up to the discretion of a facility, although there are 8 discrete elements for the compliance program. Switching gears, the other panel that, again, I was honored to participate in is substance use disorders, resident rights and resident safety. Where is the line? And Dr. Swati Gore and Dr. Jen Anzen, both of whom have subspecialties in substance abuse, graciously invited me to speak about that. There are regulatory requirements, and as everybody knows, CMS has provided additional guidance dealing with the admission rights of individuals that have opioid use or substance use disorders. In fact, there have been a couple of landmark cases recently out of North Carolina, and I'll end with this. Sunnybrook and one other North Carolina facility were sued because they denied admission to a prospective resident on the basis of his substance use disorder. They settled that case, and again, the regulations are pretty clear from CMS in terms of admitting residents with substance use and opioid use disorders. I'll end here because I realize we're running short on time. And again, it's an honor to participate. Thank you.
Appreciate it. Carrie, I think you had some slides.
I do, and I can just kind of show like one, and that'll give you a sense for what's happening. So can you see that?
It's coming up.
Okay, great. The session that we're doing is a pre-conference workshop. Is it coming up now?
Yeah, thank you.
It is? Okay, great. And this is an open door to the research. And so what we're hoping to do is just give folks a sense of what this can look like for anyone. And so here's the workshop timeline. Essentially, we have a really great presentation by Joe Auslander, and it's really the arc of his entire research career and what that's led to and what that's been what parts of that have been very frustrating and disappointing. So it's a really interesting presentation. Then we're going to talk about next steps, which is a grant we have to establish research infrastructure in nursing homes. And there's a large data set from thousands of nursing homes called the Long-Term Care Data Cooperative. We're going to talk about how that can be used. And then we're going to workshop some of the ideas that our attendees have about research they might do in their facility. And so this is kind of the overarching plan. We're going to talk about research in post-acute and long-term care. We're going to talk about how you can join a research team, how you can become a site for research, and then how you can implement research. And that's enough from me. So would love to see you. It's a pre-conference. So it starts on Wednesday.
I'm signed up to attend. I can't wait. Yeah.
Yay. It will be fun.
Raj, we have a minute left if you'd like to tell us about your upcoming presentation.
Yeah, I can keep it pretty brief here, saying I know we just have a short time. Pretty Raj Rai here from here in Colorado, obviously. Had the opportunity to present and put together a presentation with Chikal Patel and our very own Singh Pallet. And we put this presentation together on peripheral arterial disease identification and management, updating some of the management guidelines. And so really learned a lot from this presentation. I think you would learn a lot as well. Some of the things that I found, very high value to me was just the impact that it had on different populations, different demographics. For example, 10 to 12 million adults in the U.S. over the age of 40 are impacted by peripheral arterial disease. Of those, 1 in 3 Black adults also are at a risk of developing, and out of those 1 in 3, 80% there's an 80% higher risk of actually amputation in Black adults. So very impactful. And then one of the other things that I can just touch on briefly is just the impact of depression on peripheral arterial disease and how that factor, which is something that you don't even think about. You think about diabetics and smokers and elderly adults. But depression actually also has a very significant impact on development and amplifying or increasing your risk of PAD just due to chronic stress and chronic inflammation. So I know we're out of time, but just what can you do? You can attend. Come and learn more. So there, I'll leave it there.
It's a great way to end. Thank you to all of our experts and all the upcoming presenters. Good luck. Thank you for representing Colorado. And to all of you who jumped on, I hope you'll sign up for the conferences coming up. We'll see you on Thursday for Journal Club. Thank you.
Thanks so much, Singh. That was impressive.
I'm trying to pack it in. At the end, we made you guys rush.
Oh, no, now I wish I'd gone faster.
But that was a lot. That's a lot. And I hope that you're really proud of Colorado because, we got a lot,
It's amazing. I can't wait to see everybody.